Welcome everyone to our next edition of the AAP SoNPM Journal Club webinar. It's my pleasure today to have two prominent neonatal hematology, neonatal brain injury / development mentors for this session, the two most prominent world-renowned experts on this topic. So we're very grateful and lucky to have them. We have Dr. Robin Ohls today joining us, as well as Dr. Sandra Juul. And today's presentation will be led by Dr. McKenna Straus, who's a fellow at Hopkins All Children, Florida. So we have a very interesting topic. It's on Darbepoetin red cell mass and neuroprotection in preterm infants. And both our mentors have extensively worked on erythropoietin and how it helps with the neurodevelopmental of infants. So a lot of exciting things to hear from them today. With that, I'll have Dr. Brian King introduce mentors today.
Thanks for joining, everyone. I have the pleasure of introducing Dr. Ohls, Dr. Robin Ohls. She received her medical degree from the University of Utah, where she also completed her pediatric residency and fellowship in neonatology. She spent 23 years there and then has, after 23 years at the University of New Mexico, she then returned to the University of Utah in 2019, where she holds the August L. Jung Endowed Chair and serves as the professor and chief of neonatology at the University of Utah. As Viral mentioned, for 35 years, she's dedicated her clinical and research career to critically ill preterm infants, with a particular focus on translational and clinical research evaluating fetal and neonatal hematologic development, neonatal anemia, transfusions, and red cell growth factors. She's led numerous NIH and foundation-funded studies and has published more than 300 peer-reviewed articles, reviews, and chapters. She is currently advancing the concept of neonatal transfusion stewardship at national and international conferences, and she's widely recognized for her collaborative leadership and commitment to mentoring the next generation of neonatologists, like tonight. She's a founding member of the University of Utah's NeoHeme team, promoting research in all aspects of neonatal hematology and transfusion medicine. And most importantly for today, she was the principal investigator for the Darbe trial, which we'll be talking about today. So thank you for joining us.
With that, it's my pleasure to introduce Dr. Sandra Juul for this meeting. Dr. Juul is the professor of pediatrics and neuroscience at the University of Washington. She leads a translational neonatal neuroscience research program and has been continuously NIH funded for over 25 years. The focus of her research is to identify new therapeutic approaches to neonatal brain injury, determine whether they are safe and effective, and if so, bring these new treatments from lab to the bedside. She's also the principal investigator on two large phase 3 trials to evaluate erythropoietin as a neuroprotective agent, and is currently leading a trial to decrease transfusions while maintaining iron sufficiency in preterm infants. And she serves an excellent expert to join Dr. Ohls for this topic today. She has published over 250 peer-reviewed articles, and many of us trainees has been very impressed by those articles and been inspired by it. Dr. Juul is now the director of the Institute on Human Development Disability, as well as the Intellectual and Developmental Disabilities Research Center, which are dedicated to enhancing the lives of individuals with developmental disabilities. She's also very focused on neonatal trainees, and we are excited to learn a lot from her today. With that, I'll have Dr. McKenna share her slides and start the session. Just housekeeping stuff. If anyone in the audience have any questions, feel free to put it in the chat and we'll address them one by one at the end of the session. And only the mentors are allowed to interrupt the session while it's going on so that the flow is maintained. Thank you.
Great. Thank you. I'm McKenna Straus. I am a third-year NICU fellow from Johns Hopkins All Children's, and I'm so honored to be here. Thank you for having me. I'm very excited to present on Dr. Ohls' paper, Darbepoetin red cell mass and neuroprotection in preterm infants, a randomized clinical trial that was published in JAMA Pediatrics. So to set the stage, as we're talking about Darbepoetin today, we first started looking at erythropoietin in the 1980s and 1990s. And this was really focused on regards to the potential to reduce the number of red blood cell transfusions that were required in the preterm infant. Following this, in the early 2000s, we started looking at Darbepoetin due to its longer half-life, its weekly dosing requirement, and these trials really compared the efficacy and dosing to EPO. Just to review the mechanism of action, darbepoetin and erythropoietin are erythropoiesis-stimulating agents, with Darbe having a longer half-life than erythropoietin. They bind erythropoietin receptors on the surface of hematopoietic progenitor cells in the bone marrow. This then activates the JAK2 kinase signal transduction pathway, which leads to proliferation, differentiation, maturation, and inhibition of apoptosis of red blood cells. While investigating the hematopoietic effects of EPO in the early studies, some preclinical models showed that EPO actually acted as a neuroprotective agent as well. This led to the performance of trials to determine if this held true in the preterm infant. As we all know and are familiar with, our premature infants are subject to various pathologies, including infection, hypoxic ischemic insult, and ventilation injury, leading to a state of inflammation and cell death. This persistent state of inflammation can ultimately lead to neurodevelopmental impairment. Since these preclinical animal models, we've done studies that have revealed not only the hematopoietic benefits that we're familiar with, such as a reduction in red blood cell transfusions, increased red cell mass, but also have showed non-hematopoietic effects that may improve neurodevelopmental outcomes. And these include decreasing apoptosis, decreasing inflammation, increasing neurogenesis, and increasing oligodendrogenesis. So really the first study to look specifically at these neuroprotective outcomes of erythropoiesis stimulating agents was Dr. Ohls' randomized controlled trial in 2013. This study looked at 102 infants receiving either darbepoetin, EPO, or placebo. They showed the expected hematopoietic benefits of fewer transfusions, fewer donor exposures with those receiving their erythropoiesis stimulating agents, and the benefit to Darbe being its longer half-life, weekly dosing as opposed to 3 times weekly dosing of EPO, ultimately leading to fewer injections, which I'm sure the baby and the families were happy about. So both ultimately were shown to be safe and successful adjuncts to transfusions for our preterm infants. They then did the 2-year follow-up study that revealed infants receiving Darbe or EPO had better cognitive outcomes when comparing to infants receiving the placebo. They looked at cerebral palsy and those who received erythropoiesis stimulating agents. There were no infants reported with CP in that group versus 5 that developed it in the placebo arm. Importantly, when comparing infants who received EPO and Darbe, the 2 groups scored similarly in regards to their composite cognitive, language, social, and emotional scores. But the Darbe recipients had a statistically significant increase in object permanence scores compared to the EPO group. Object permanence scores can be used as an early measure of executive function, and therefore it was theorized that maybe Darbe was superior to erythropoietin in terms of developmental outcomes. And this becomes the basis of the study that we're going to later discuss. Outside of the Ohls study, there have been conflicting results in terms of the neuroprotection with erythropoietin specifically. So an early study in 2010, looking at 200 ELBW infants that received early erythropoietin, revealed that infants scored significantly higher in developmental and psychological assessments. This study was then followed by Dr. Song's trial in 2016, where 800 infants were randomized to either erythropoietin or placebo, starting within 72 hours and then continued for 2 weeks. And this also showed that infants receiving erythropoietin had significantly lower rates of neurologic disability compared to infants that received placebo. So with Dr. Song's findings, the Swiss Erythropoietin Neuroprotection Trial Group performed this trial in 2015, investigating specifically high-dose erythropoietin given to premature infants, starting shortly after birth over the course of 2 days. So they looked at 443 infants, randomized to high-dose EPO, which they used 3,000 units per kilo as their high dose, or placebo. The original study was to investigate the short-term outcomes and safety, which revealed no difference in mortality or major adverse events, and did show the hematopoietic benefits that we've come to expect, including higher hematocrit, higher reticulocyte count, and higher white blood cell count in those receiving the erythropoietin. When they did their 2-year follow-up, they did not see difference in neurodevelopmental outcome between infants receiving the high-dose EPO compared to those receiving the placebo, unlike the previous trials. This was followed by the Peanut trial that came about in 2020, which was a phase 3 randomized placebo-controlled double-blinded trial looking at 741 infants. This study once again found no difference in neurodevelopmental outcomes between infants receiving high-dose erythropoietin versus infants receiving placebo. They showed no difference in retinopathy of prematurity rate, which was an early concern in original trials that erythropoiesis-stimulating agents would increase this risk, but luckily this was not found. They also found no difference in adverse events, including IVH, sepsis, NEC, BPD, or death, some of which were found in other studies. And then similar to other trials, we showed the lower number and volume of transfusions required and lower number of donor exposures. So with this, the current recommendations are that darbepoetin is not FDA approved for neonatal or preterm use. And per the Cochrane review, looking specifically at early erythropoiesis stimulating agents in preterm or low birth infants, they concluded that darbepoetin and erythropoietin do reduce the number and volume of transfusions and donor exposures, although potentially a small reduction and maybe with limited clinical importance. They did find that early erythropoietin in a lot of studies did reduce the rates of IVH, PVL, and NEC. But the neurodevelopmental outcomes specifically really varied, and there was conflicting neuroprotective effect. So as of right now, erythropoietin is not currently recommended, and they report that further studies of erythropoietin as well as darbepoetin are required to make such recommendations.
Dr. Ohls, we can take a pause here, and this is a question for you because we have a lot of young investigators in the audience. Can you walk us through how you are able to bring a bedside to bench approach to this trial, doing your first Darbepoetin trial, and how was your understanding of the literature and how we have come so far to this trial? Dr. Straus gave us a really brief review, but some insight from you would be great for all the young investigators.
Yeah, well, we've been studying red cell growth factors in preterm babies since 1989. So we had quite a few years of experience, but it was really Sunny in the lab that identified EPO receptors in the fetal tissue that we were able to collect, and went on to show significant improvements in neurodevelopmental outcomes in preclinical models. We looked at benchtop growth of fetal neurocells with EPO and Darbe, and found that there were an increase in markers reflecting increase in progenitor cell production with darbepoetin over erythropoietin. But certainly EPO was, we started using EPO in babies, and darbepoetin wasn't supported by a lot of pharmacies in hospitals throughout the country back in the 90s. So a lot of our initial studies were on EPO and preterm babies. And it was shown that using red cell growth factors, the hematopoietic changes and effects have been significant and consistent throughout all the studies that we've done. And it's really just the newer studies that we've done in the 2000s looking for similar improvements in neurodevelopmental outcome that have been seen in preclinical trials, and a lot of these trials that Sunny has done in her lab, showing improvements. We've not been successful in identifying the best population, I think, to benefit this way. But certainly, I would argue that the benefits of decreasing transfusions and donor exposures in babies, at least in our study, doubling the percentage of infants less than 28 weeks gestation that received 0 red cell transfusions during their hospitalization is significant. And that is an improvement. And it's a reason to use darbepoetin or erythropoietin in our smallest babies. So we've done a number of studies looking at different neonatal populations, term and preterm infants, surgical infants with late anemia due to ABO incompatibility or Rh hemolytic disease. And in all of these studies, we've shown an improvement in red cell mass in these infants and a decrease in transfusion requirements. I think Sunny probably is the best person to talk to about the transition and connection between hematopoietic improvement and neurodevelopmental improvement in babies and how these may be connected.
Yeah. Dr. Juul, do you want to comment on that? It'll be a great way to bridge the preclinical to clinical science and set a basis for the study.
Sure. So when we first started this work in the early 90s, we started because there was an article showing EPO receptors on cultured neurons. We were like, what on earth is it doing there? And is it there in humans? And so, like Robin was saying, we looked at some human fetal tissues and documented that EPO receptors were present in human brain and actually synthesized in the brain from early on in development. It's synthesized by glial cells. And our thought at that point was that EPO might work similarly in brain as it does in bone marrow. So in bone marrow, as McKenna was saying, it increases the maturation and development of red blood cells and decreases programmed cell death. So we thought maybe it would do the same thing in the brain. And we did a lot of early work looking at neuroprotection and inflammation and so forth. But it was primarily done in rodents. And I think one of the take-home points for this is that the physiology of rodents is quite different than from humans. And like there were several labs that showed EPO decreased inflammatory mediators following brain injury. And we were pretty certain that that was one of the things that we were going to see in both the peanut trial and the HEAL trial. But it turns out that wasn't the case. And there was absolutely no difference between inflammatory mediators in the placebo versus the EPO-treated group. So I think, it's lessons learned. And I think the other big thing that that Robin didn't talk about yet is the interaction of iron and erythropoiesis. And so we know that iron deficiency during critical periods of brain development is bad for your brain. It doesn't develop normally. And we also know that if you increased erythropoiesis that increases iron utilization and potentially can make the baby and the baby's brain be iron deficient during basically the last trimester when they're living in the NICU. And that was certainly something that we saw in the peanut trial. So when we came up with the protocol for the peanut trial, the different PIs so it was 19 NICUs and 19 sites and 30 NICUs. It was 940 babies that we enrolled.
900. Yeah, I thought it was 940. Yeah.
Yeah, it was 940, and we agreed on everything except transfusion protocols and
Iron.
at the time.
So hard. Yeah.
Yeah, at the time, like there was a lot of really disparate views on iron administration. And there were like the old neonatologists that were like, it's going to cause oxidative injury. Iron is bad. We don't give it to babies until they're 2 kilos or 2 months. And then there was the other group saying, no, it's really essential. And if you're born at the beginning of the 3rd trimester, you miss 80% of the iron that you normally get through the placenta during the 3rd trimester, and that's bad. And so, so what ended up happening is that babies who were on the EPO arm of the peanut trial were much more iron deficient than the babies in the placebo trial. And we don't know why we didn't see a positive effect on neurodevelopment, but that's certainly one potential. And so that's like unintended consequences, right? You try and think of everything, but it's hard.
And it was so hard to convince a lot of the sites. I mean, Sunny went through this and I went through this. We sort of divided up the sites to be the, I don't know what we would call ambassadors or just protocol advisors, but at least half of the sites that I was supervising had never even used iron in the NICU. Like the best they would do, they would give iron when the baby was going home in the form of a multivitamin with iron. So to try to convince folks to start iron in the first week of life was that was a heavy lift, I would say. But in both the peanut and Darbe studies, infants that received more iron had improved developmental outcomes. So
Yeah.
we published those and you know, and that is in all the babies, regardless of whether they were in the ESA groups or the placebo groups. So it's a really important sort of side effect, but also interesting and challenging new area of research, I think, is looking at. And Sunny's the chief mentor for Kendall German, who has done a lot of this early work at the University of Washington and is doing a great job.
Yeah, so some really good points for the young investigators, a very sound basic science for it and how it led to this trial. McKenna, you want to proceed with your slides?
Yeah, so thank you. That leads us into our discussion today. So we're looking at the randomized clinical trial, Darbepoetin red cell mass and neuroprotection in preterm infants, led by Dr. Ohls and published in JAMA Pediatrics.
Oh,
So-
and can I just add one more thing, McKenna? Can you go back a slide?
Sure.
So this is something that you can see the title is Darbepoetin red, and this is a truncated title that JAMA Pediatrics makes you squish into something. But for me, when I wrote this protocol for the network, my focus is primarily on improving red cell mass, and with an increase in red cell mass, you get fewer transfusions, which may decrease inflammation. You have an increase in oxygen availability to tissues, whether you're using it or not, but you have higher hematocrits and a higher red cell mass despite lower transfusions. And all of those components should help to improve neurodevelopmental outcomes. So anyway, I just wanted to point out that that's why I titled this. They wanted us to kick out the red cell mass part, but I was like, you know, that's the first step, is that you have to increase the red cell mass in order to maybe see neuroprotection. Okay, sorry. I just wanted to point that out.
Makes sense. Right. So the author's hypothesis is that preterm infants given weekly darbepoetin at 10 micrograms per kilo per dose would have better neurocognitive outcomes at 22 to 26 months corrected compared with infants receiving the placebo. With the previous trials that we discussed not showing a consistent neuroprotective benefit for EPO, the question is raised as to why we think darbepoetin with a similar mechanism of action and therefore presumed neuroprotective effect would be different. But the basis really seems to stem from the previous study showing the statistically significant difference in object permanence scores between erythropoietin and darbepoetin recipients, leading to the theory that Darbe may be superior in terms of neuroprotection. And if there's more to it, Dr. Ohls, you can chime in, but that seemed like where it sort of stemmed from.
Yeah, the trend was all to show improvement, not only at 2 years, but at 4 years and 6 years as well.
So looking at the PGOT summary, our patient population were infants born between 23 and 0 and 28 and 6 weeks gestation. The intervention being darbepoetin at 10 micrograms per kilo, administered either IV or subcutaneously, depending on access, from 36 hours of life through 35 weeks postmenstrual age. The control being placebo IV normal saline or a sham subcutaneous placebo, again, depending on access. The outcome being the Bayley-3 cognitive composite scores, and the time frame to obtain these were a goal of 22 to 26 months corrected. This was a multi-center randomized clinical trial at 19 U.S. Neonatal Research Network centers comprising of 33 NICUs. Was consented enrollment between the dates of September 2017 and November 2019. Again, we included infants between 23 and 0 and 28 and 6, and excluded infants who had known congenital or chromosomal anomalies, hypertension, seizures, thrombosis or hemolytic disease, no plans for aggressive therapy or unlikely to survive, receiving erythropoiesis stimulating agents clinically or unlikely to be available for follow-up. The infants were essentially randomized 1-to-1 to the 2 study arms. There was 2 gestational age strata, so 23 and 0 to 25 and 6, and then 26 and 0 to 28 and 6. Multiple births were assigned to the same treatment group, and all caregivers remained masked to the drug assignment. Study procedure-wise, the treatment that we talked about is the darbepoetin weekly, or the placebo, IV normal saline or sham subcutaneous placebo, initiated at 36 hours of life and continued through 35 weeks, postmenstrual age, discharge, or transfer. And then uniquely to this study was the iron protocol that was put in place, as we just learned how important iron is to this process and the potential neuroprotective effects. So both groups received parenteral or enteral iron dosing. So parenteral if you were receiving less than 80 per kilo of feeds, and then transition to enteral iron once receiving 80 and greater of enteral feeds. And then they did iron monitoring as well and adjusted the dose based on this. And this occurred at days 14 and 42. A CBC was obtained at minimum at baseline, days 14 and 42. And then there were transfusion guidelines that were recommended, but not mandatory. So to give you an idea, this is the iron and transfusion guidelines. So as you can see in the top, the iron dosing was adjusted based on ferritin levels that were obtained at day 14 and 42. And then the transfusion guidelines in the lower box, which were fairly restrictive and based on the level of respiratory support. The follow-up was assessed. Infants were assessed at 22 to 26 weeks, corrected gestational age, with the Bayley Scales of Infant Development 3. And a neurologic exam was done for cerebral palsy. Examiners were masked to the treatment arm as well. The primary outcome was the Bayley-III cognitive composite scores. And of note, a score of 54, which is the lowest possible score, was assigned to infants who died. So they were included in this primary outcome. The secondary outcomes included the Bayley-III composite scores in surviving participants alone. And then the hematopoietic benefits, so red cell mass, hematocrit, reticulocyte count, red cell indices, number and volume of transfusions, and donor exposures. They also looked at hospital days, differences in adverse effects, including thrombosis, hypertension, and seizures, rates of IVH, NEC, BPD, retinopathy of prematurity, neurodevelopmental impairment, death, and cerebral palsy. 650 infants, or 325 per arm, were chosen to provide a 90% power to detect a difference of 5.6 in the cognitive composite scores. And this power calculation is a little more complicated because it takes into account the deaths, assigning that lowest score, as well as an expectation of equal number of deaths, which they ultimately ended up having. Interim monitoring and analysis occurred after 20 participants enrolled, and then 25, 50, and 75% enrollment. They used an intention to treat analysis, and then primary analyses and analyses examining outcomes were adjusted for gestational age, center, and family clustering. General linear mixed models were used to adjust the mean difference in cognitive scores, and then categorical outcomes and secondary count outcomes were analyzed with Poisson regression. Oops. So a total of 2,625 infants were assessed, with 2,299 found to be eligible. Notably, 1,649 were excluded, with the majority being due to parental refusal. So a lower enrollment rate there. 650 infants were ultimately enrolled, and then included in the intention to treat analysis were 319 infants in the Darbe arm and 328 infants in the placebo arm. 50 infants from each arm died before discharge. So a total of 583, or 90%, ultimately ended up having complete data for the primary outcome, and that included the 105 infants who died.
Dr. Ohls, can you, specifically looking at that refusal, and knowing that, one of the benefits of Darbe versus EPO is its dosing, were you surprised? Was that what you were expecting? And I actually don't recall, Dr. Juul, if you recall how that compares to the experience in peanut with EPO.
I can't remember what the peanut consent rate was. I mean, if you think about it, interventional trials in extremely low birth weight infants are very hard to implement. And being in the Neonatal Research Network, we do a majority of our studies in babies less than 1,000 grams or babies less than 29 weeks gestation. And if you can imagine asking a family who's all of a sudden having a baby that weighs 600 grams being born, and asking if you can randomize them to a study that is looking at a medication to see if there's improvement, it's a heavy lift. I would say that we would love to, we always anticipate, a 40% consent rate, but I would say that this is extremely expected, is to have about a 30% consent rate in our interventional studies in our very, very tiny infants. And in fact, I would say, and Sunny, you can second this if you can, but it really, since the initial cooling trials in babies with HIE were, again, very critically ill infants, completely unexpected for families, and then they're asked to be randomized to their baby being cooled for 3 days or not. In those trials, initial trials, the consent rate was close to 90%, because it was considered something that was life-saving if possible, that could have been life-saving. But the studies we do now, and with the added burden or benefit of the internet, and one of these things that has every single answer on in the whole world on it. It's really hard to talk to families and have them consent. It's a great privilege to have these babies in our studies. And I can tell you, I think it's probably going to get worse before it gets better, because the lack of trust in medicine in general has really grown, and probably will not improve for at least 5 years, 5 to 10 years.
You're muted, Dr. Juul.
Yeah, we have a current ongoing trial looking at Darbepoetin plus IV slow release iron, and with the transition of presidents, and we saw a dramatic drop in people willing to say yes to research. Yeah, it's quite remarkable. I think between Kennedy's, naysaying all the things that we have really good evidence for, and just that general attitude about sort of denying expert opinion, it's really had an effect on enrollment.
Yeah. So, I mean, it does bring into question how generalizable are studies moving forward, right? And doing large multi-center trials like this and like Peanut, they're sort of a double-edged sword. You gather pilot data from your own institution or from institutions that work clinically very similarly, and you can have a very small standard deviation or standard error in those initial findings, which can encourage you to branch out into a multi-center trial. But you end up dealing with a lot more variables once you deal with, like Sunny said, 30 different hospitals that are trying to follow a specific protocol. So generalizability is always going to be an issue from this, from moving forward.
Yeah,
Thank you.
that's actually one of the take-home points, I think, is at least from Peanut, when we looked at other things that affect neurodevelopment, like chronic use of steroids or benzodiazepines and opioids and stuff, that definitely had an effect on neurodevelopmental outcomes, and they vary dramatically between the different centers. It's just, and that wasn't one of the things that we had in the protocol. Feeding, breast milk, so many things affect neurodevelopment, and you can't plan for all of them.
Yeah.
So
Easy to control in your own center, but hard to control for everybody.
Exactly.
Yeah.
Some great points for trainees whenever to evaluate a trial. Look at the figure 1 and the generalizability of the trial.
Yeah.
Dr. Straus, you can proceed.
Yeah. So with this, I just looked into the supplemental information a little bit, and luckily you guys reported that there were similar rates amongst those who were randomized and those who were eligible but not randomized in terms of patient characteristics. So they're including race, ethnicity, and maternal education. The infants randomized did look like they had a little bit lower birth weight compared to those eligible but not randomized, so 830 grams versus 875 grams, so a small difference there. And then out of the 319 infants who were in the Darbe arm, 92% of them completed the planned protocol, and 94% of infants in the placebo arm did. Looking at the patient characteristics, they were very similar between the two study arms, with nothing really jumping out in terms of differences. And then moving into the primary outcome, so the Bayley 3 cognitive composite scores. When evaluating this 291 infants in the Darbe group and 292 infants in the placebo group were included. This reflects the infants who followed up as well as the infants who died. So as you can see, the cognitive scores did not differ between the two study arms, and this remained true after adjusting for gestational age, center, and sex. Now, I was a little curious in terms of the effect of assigning the infants who passed the lowest cognitive scores and how that changed the outcomes. Looking into the supplemental information, the authors did do a post hoc analysis looking at this. So you can see that this looks at just the subjects surviving to follow up. The mean scores are a little bit higher as you're not accounting for those low scores with those who passed, but overall remains similar between the two study arms. And this makes sense because the deaths in each arm were almost the same.
Yeah. I mean, if you use a continuous variable like the cognitive score, the statisticians are always pessimistic. And so they make you assume that all the babies that died are going to have just horrible brain damage. But I'm sure there were some geniuses that passed away in our study as well. So it's a tough thing. So Peanut was not continuous variables. It was neurodevelopmental, it's death or neurodevelopmental impairment, which a lot of studies use that as well. But for sure, we saw some differences in the two stratified groups as well.
Did you look at gestational age? Like, did you look by week?
Yeah, well, we looked at just the two stratifications, and definitely there was the smallest babies, very tough to show improvements. Those babies at 23 to 25 weeks gestational age. So, and the cognitive scores reflect that, I think. And there was a trend towards improved cognitive scores in the larger population of kids. And I would say that the larger kids were more similar to the initial Darbe versus EPO versus placebo study that we did, in that they were sort of 27 weeks-ish and more like 900 grams. So bigger kids, a little bit easier to get them to avoid transfusions, improve their red cell mass. Smaller babies are going to be exposed to all of the morbidities that we know about in our tiniest babies. And then I know the Peanut, we did see some trends as well in some different gestational ages.
That's what's up on the screen now. So this is the post hoc analysis looking at the cognitive scores by gestational age strata. So the 23 to 25 and 6, and then the 26 to 28 and 6. And you can see that the higher mortality in the more immature group, exactly what you said, has an impact on the cognitive scores in the group, and then everything that comes along with being more premature. So looking at the secondary outcomes, 319 infants in the Darbe and 327 infants in the placebo were included in the intention to treat analysis. So the infants receiving darbepoetin were much more likely to have never received a transfusion compared to the placebo at double the rate, like you said, 40% compared to 21% in the placebo. The Darbe recipients received, less transfusions as well if they did require a transfusion. They saw a lower number of donor exposures in volume of transfusions. Unlike some of the other previous studies, this did not find a difference in rates of IVH, PVL, or NAC, but similarly report no difference in retinopathy of prematurity. Unexpectedly, they saw a reduction in BPD in the Darbe group, so 34.9% compared to 46.2% in the placebo group.
Can we go back real quick? McKenna, you mentioned with some of the past trials that some of these outcomes have been positive in some trials and negative in other trials. So here we have no impact on IVH and NEC, which we've kind of seen in other trials, but then this other outcome of BPD. What do you think, Dr. Ohls and Dr. Juul, about like what's what's real about these sort of in-hospital outcomes as opposed to the neurodevelopmental outcomes, because they seem to be inconsistent across the trials.
Yeah. So, and it looks like Linda did put in some information in the chat. So, one of the things about both BPD and ROP is that babies that don't receive transfusions or receive very few transfusions are not exposed to hemoglobin A, like babies that do get a lot of red cell transfusions. And certainly for ROP, there's a significant association between the number of transfusions that babies receive, since they're all receiving adult red cell transfusions with adult hemoglobin. And there was a recent study out of Italy called the Born Trial that looked at comparing babies that received umbilical cord blood red cell transfusions versus adult red cell transfusions. And we're trying to we're following along with our colleagues in Europe in looking at this. But for those babies that received per protocol the cord blood transfusions versus those babies that received adult transfusions, or there's a lot of crossover in those cord blood transfusion babies because sometimes they didn't have cord blood available to transfuse. So a bunch of them got adult red cell transfusions. But for those babies that just got cord blood transfusions, there was zero incidence of severe ROP in that group. And so again, it's a smaller study, but something I think definitely worth pursuing, and we are also pursuing that at the University of Utah. Let's see.
It's interesting, though, then, if you compare this to the transfusion threshold trials, right, where the intervention was specifically to give less transfusions,
Right.
this BPD effect is huge in comparison to,
I know.
the lack of
We were
difference
not
seen in
expecting that.
often.
But there's a plausible explanation. And when you look at the two transfusion trials, Etno and TOP. So in TOP, which was the study we did through the network, similar size of babies that we're showing here in the Darbe study, there was absolutely no difference in BPD between the two groups, but there was a significant difference in BPD between TOP and Etno. And there was also a significant difference in the number of transfusions that the babies received in TOP, where transfusions were mandated, versus Etno, where transfusions were also mandated, but not for up to 72 hours after they identified the hemoglobin or hematocrit that reached the transfusion trigger. And so this is likely a multifactorial effect. And so we can look at inflammation. We can look at a hemoglobin A versus hemoglobin F. So when you give red cell growth factors to preterm babies, they make hemoglobin F, right? So they're making their own red cells, they're increasing their red cell mass, and they're also exposing to their tissues to lower oxygen delivery because of the hemoglobin F. So I think the BPD, I think it's real because the data that is collected through network studies is very well collected data. And Eric Jensen's going to publish a secondary analysis of the BPD statement, and there are fewer kiddos that were on oxygen and on ventilators at 36 weeks corrected gestational age for these infants. So I think it's real, and there's plausible explanation for it. Again, it is secondary analyses, so you have to take it as hypothesis generating, and that's what we do. So I don't tell people that giving EPO decreases your BPD rate, but certainly I tell people if you give your babies red cell growth factors, they will receive fewer transfusions, and that's really important.
So we did not see a difference in BPD in the PNET trial. And we had 13% of babies that didn't get any transfusions at all in the placebo group versus 28. So double, just like in your group, but didn't see any difference in BPD, PDA, NEC, IVH, any of those things. They were really exactly the same. The only difference we saw in secondary, preterm complications was blood transfusions were decreased.
Yeah. And I would say that we're close to gaining significance with early administration of red cell growth factors in babies and decreasing the incidence of ROP, which is very exciting. And Sunny and I, with Bob Christensen, wrote a editorial a couple years ago about the early Cochrane reviews, which raised alarm in many NICUs that caused everybody to stop using red cell growth factors based on incorrect analyses of the studies that had been performed during that time. So I'm hoping that the Cochrane reviewers currently lay that to rest, that red cell factors do not cause ROP. In fact, they may prevent ROP in babies.
Keep going, McKenna.
Wonderful. So I did just want to point out that we talked earlier about the fact that there was the iron protocol that was in place, and then the transfusion guidelines, although not mandatory. There were a large number of events that were deviations, although, some of them were minor. But 55% of the Darbe recipients did receive a transfusion outside of the protocol, and 66% in the placebo arm. So just keeping that in mind when talking about some of these results.
Neonatologists are terrible at following protocols, is what that.
Yeah, they are. And actually that value, that's something I need to follow up on, McKenna. I'm glad you pointed that out, because I'm trying to remember if I reminded the statisticians that not transfusing a baby when they reached a hematocrit trigger was not a protocol violation. So that might have been it. It was probably there were probably about a fifth of the babies in the placebo group whose transfusions were given, at a hemoglobin or hematocrit a little bit higher than we would have liked them to be at. But it is a really tough thing. We have really restrictive transfusion guidelines at the University of Utah and all of our NICUs in Utah, and it is still tough to get them to pay attention to the guidelines that we've all agreed on. We've just instituted some electronic medical record alerts so that neonatologists, just like all the other intensivists in the hospital, now have to follow guidelines to order blood from the blood bank, and the blood bank will say, nope, you don't qualify yet, which is what they do for all the adult intensive care patients. But neonatologists get to order anything, anytime right now still.
This figure looks at the secondary outcomes of red cell mass, hematocrit, and absolute reticulocyte count, with the mean outcomes of Darbe recipients in yellow and the placebo infants in blue. The x-axis is demonstrating the age in weeks. So as you can see, despite receiving fewer transfusions, by week 2 of age, Darbe recipients had larger red cell mass seen in A, higher mean hematocrit seen in B, and a higher reticulocyte count seen in C. This was seen starting at 2 weeks of age and continuing through the study period. I thought, interestingly, the mean hematocrit in the placebo group doesn't seem to drop below 30, despite being in the time period of a physiologic nadir and despite these restrictive transfusion guidelines. So I wasn't sure if the deviations played a role in this or not.
Yeah, that's a good question. But again, if you see, if you were able to maintain your tiny baby's hematocrit in the 30s, that's pretty dang good.
Oh, yeah.
So again, I would emphasize that I don't think that this is insignificant.
Definitely. And I think the other thing that, at least in our institution, when we were going through this, noticed was that the hematocrit for the Darbe recipients, despite being on it continuously through the study period, remained under 40. So our protocol is that we stop the Darbepoetin at a hematocrit of 35 for fear that it's going to keep going up, but that seems to not be the case. That we, infants eventually regulate and kind of stay at a steady state. So in conclusion, it seems that Darbepoetin administration to preterm infants did not result in higher cognitive scores at 2 years of age. Darbepoetin recipients were more likely to be transfusion-free, received fewer transfusions, were exposed to fewer donor exposures, had higher hematocrits and greater red cell masses than placebo recipients. And lastly, the unexpected lower incidence of BPD amongst Darbe recipients requires further study. So talking a little bit about the BPD, you kind of brought it up already in terms of, the theory behind that. It looked like the secondary analysis of the PEANUT trial did see a higher volume of transfusions was associated with increased BPD. And then talking about the hemoglobin, fetal hemoglobin, as you were discussing, the trial by Hellstrom showed that decreased fetal hemoglobin during the first postnatal week was associated with higher risk of development of BPD. So therefore, maintaining a higher hemoglobin F percentage through Darbe or EPO may be protective. And then in addition with the transfusions and lower exposure to the hemoglobin A, as you discussed. And then I saw that the transfusion of prematures trial found the association between higher number of transfusions and increased risk of BPD. The strengths of this paper, it was a multi-center design with experienced investigators and research coordinators through the NRN. It was the first large masked randomized controlled trial to evaluate darbepoetin as an erythropoiesis stimulating agent to improve red cell mass. It's certified evaluators assessing follow-up, and it was the first RCT to implement iron supplementation and specific restrictive transfusion protocols, as we discussed how important that is. The limitations, as we discussed, the lower enrollment rate, although it seems, that's fairly expected, especially nowadays, with 28% of the eligible infants being enrolled, as we discussed. There were follow-up challenges with the original goal of evaluation at 22 to 26 months, which 88% of those surviving did follow up, but 61% of those infants were met in the goal time period. So the mean corrected age at follow-up was 27 months, so a little bit later, and this was attributed to COVID times, so infectious disease policies.
Bad timing for our follow-up, really bad, yeah. So a bunch of our 2-year-olds couldn't be seen because the clinic said, well, they have to wear masks, and 2-year-old former preemies don't keep masks on their face. So yeah, it was tough. It was tough getting them in.
I think for the HEAL trial was during COVID was the follow-up. So yeah.
So missing or late to follow-up data due to COVID infectious disease policies was looked at with a sensitivity analysis that was performed and showed that Darbe recipients missing the primary outcome needed to show an average improvement of 15 points on their cognitive composite scores to change the conclusion, which was felt to be highly unlikely. Mm-hmm. And then lastly, the secondary outcome results in post hoc analysis considered hypothesis generating that we talked about with the BPD. Mm-hmm. So moving forward, we need further studies investigating the slower incidence of BPD and the association or correlation there. And then there's need for recommendations regarding the use of Darbe and EPO. They seem safe, short-term and long-term. They effectively increase your red blood cell production, as been shown over and over, and reduce the amount of transfusions, as we saw, double the infants in this in the Darbe arm went transfusion free compared to placebo. Cost effectiveness, it seems like the darbepoetin and erythropoietin are cost effective compared to transfusion costs from my quick search, but maybe not necessarily for neurologic or developmental outcomes, although more to be looked at with that, but at least for now what we've showed.
The other thing I would add is that this really points out the importance of phase 3 trials, right? There's a bunch of phase 2 trials that looked like EPO was going to be the silver bullet or Darbe. And the reason that we need to do large randomized controlled trials at different centers so they're generalizable is because the type 2 studies don't necessarily give you the answers.
Yeah, McKenna, thank you for that great talk. Sort of bouncing off that and going back to Robin, or Dr. Ohls, you mentioned very early in the talk about the importance of just that outcome of preventing transfusions and how that, the doubling of the number of infants without needing a transfusion is still a really meaningful outcome. Yeah. It does make me wonder, oftentimes we are looking for, as you said, the silver bullets of the treatments that prevent neurodevelopmental impairment or prevent death. But in this situation, what is the threshold? Like, what's a reasonable trade-off? Between weekly injections and just not getting transfusions? Like, is that not enough? I'm wondering if you have comments about qualitative work with parents on like shared decision making in practice, not in the trial setting, but actually like in the NICU setting, what parents think about this trade-off. Yeah, yes, it's a painful intervention, but if we're solely just talking about transfusions, maybe they would still think it's worth it.
Yeah.
You seem to suggest that, Dr. Ohls.
Yeah, and that's what my goal is for the next 5 years, is really emphasizing the development of neonatal transfusion stewardship in everybody's NICU, because I think it's so important. And just like antibiotic stewardship really took off in the early 2000s and now is a part of evaluating hospitals across the country, I think transfusion stewardship is very important. And there's ways that we can improve outcomes in babies, I think, in a lot of different ways. I care about blood primarily, and so does Sunny, but I can tell you that interest was certainly piqued when we mentioned any sort of neurodevelopmental improvements. In a similar fashion, people really care about lungs as well. So blood is like way down on the totem pole of things that people care about. But I think it's really important to be able to decrease or eliminate red cell transfusions and aim for a donor exposure of 1 or less in all of our extremely low birth weight infants. I think it's incredibly important. And I think we can achieve this doing the things that we know how to do and just training people. So the American Academy of Pediatrics came out with a clinical report that said, obtaining cord blood is possible in all of our babies that are admitted to the NICU, especially in our tiniest babies, though. And obtaining initial labs from the cord is very important, and it avoids that initial phlebotomy loss that you have in your tiniest babies. But in addition, doing delayed cord clamping, I think that has really been an improvement in increasing your initial red cell mass in babies. And then looking at your phlebotomy needs and really thinking about each lab that you order, not ordering a slew of labs in a row, not doing routine weekly checks of anything. You don't need to trend anything. But also starting red cell growth factors in the first week of life to improve babies' red cell mass, improve their hematocrit, increase their oxygen capability, carrying capability. I think all of these things eventually will benefit babies, and hopefully we can get people excited about it and have it be a part of their care in the NICU.
Just to go quickly through questions, I think while we were talking, I think Linda had asked a question that you addressed sort of in the moment when we talked about BPD and transfusion mechanisms. Somebody else asked about when we were talking about protocol violations. They also pointed out the iron protocol violations, which I think, as we said early on in the presentation, iron has been a somewhat controversial thing. So if there's any more comment you have on that, that was a question.
Yeah, and this was our second large multicenter trial of red cell growth factors and iron. So we actually did perform the trial way back in the 1900s and late 1990s, and we gave parenteral iron in that study as well through the network. So many of the network sites were used to at least considering parenteral iron and then enteral iron at these doses. But there's still going to be provider variability at each site, and the network sites make a commitment to follow protocols as best they can, but you're still going to be dealing with provider variability and folks that see something, they think that maybe the iron is going to be doing something harmful to the baby, and so it's held, or so that continues to be a challenge for us. But again, when we evaluated in both of these trials where babies did get iron, during a large portion of their hospitalization, that those infants that received, that's my Chihuahua pack back there. Those babies that did receive more iron actually did better cognitively. So regardless of whether they were in the placebo group or the EPO group or the Darbe group, the babies that got more iron did better. So I think it's a great area of study. And I know Sunny is doing a great study right now looking at a different kind of parenteral iron and using Darbepoetin. How far are you through the study?
We have 93 babies enrolled out of 120.
Close,
We're getting there.
very close. Is
Yeah,
it just in Washington or is it a couple centers?
it's just EW.
Okay.
Yeah,
Well, good luck with that, man. I'm very excited to see the results of that study.
thanks.
Yeah, thank you, both of you for the wonderful insight, and McKenna, great job. There was, as you were talking, there was a follow-up question about the iron and how that could, have been associated with the lack of neurodevelopmental impairment, or cognitive impairment improvements, which, as you were saying, might certainly be one reason. But if there's no more questions and no additional comments, thank you for your insight and expertise, and McKenna, great job, and thank you everyone for joining us.
Yeah, thanks,
Yeah.
McKenna. You did a great job.
Yeah. Excellent session. As you can see from the poll, 75% are influenced by the study. Even though the study results are overall negative, it is still a very important study, which has influenced practice of a huge majority of neonatologists. So it's something really commendable. So again, thank you so much for coming. Excellent presentation, McKenna. It was very well presented. We'll see you again in December for our next journal club. Thank you everyone for staying so late and joining us. We'll see you next month.
Thanks, you guys.
Thank you.
Bye-bye.